The floor is now open for questions and comments. We will read out the questions to our speakers in that order, and then our speakers will respond to that question. Meanwhile, if you have any more questions to a particular speaker, please post your questions in the chat box. And now I request Dr. Lee Luan to please start with our first speaker.
Okay, the first questions, I shall read out the questions. And the question is, should reciprocity also be a value in prioritization? A small number of countries like Canada, Spain, Ireland, and WHO SAGE group cite reciprocity as part of why healthcare workers get priority, in addition to risk and essentiality, of course. Reciprocity might also imply trial participants who got placebo should get priority, but the principle is contentious, susceptible to bias, and unclear how to systematically apply it. So this question has actually been answered by Professor Datuk Dr. Awang Bogiba. Prof, would you like to respond? But let me just,
Sure. Right. Thank you very much. You know, in clinical trials, when something has already been proven to work very well and they've reduced morbidity or mortality, then several trials have actually been stopped halfway. You know, just because the interim analysis actually showed that it's no longer ethical to continue with the trial because the one receiving the intervention was surviving longer or had less morbidity than the one receiving the placebo or the standard treatment. So that is an established concept. For example, when azidothymidine was trialed as a drug for HIV, for example, and midway, I think the interim analysis showed that the patients on the AZT were surviving much longer, or you know, compared to the ones on the placebo. At the time, there was no other drug anyway. So the trial was stopped, and all those on the placebo were given the drug. So in the same way here, once a vaccine has been established to be very effective, for example, highly effective, then you will have to, and probably ethically, you'll have to give the vaccine to the ones on the placebo. It creates, of course, another problem, because phase 3 trials are all meant to run for about 2 years. You have to monitor adverse events for about 2 years. So if you were to stop the trial midway and give everybody the vaccines, you then will not be able to compare between the vaccinated group and the unvaccinated group for that period of 2 years to see whether the adverse events then differ. So this is a principle which many epidemiologists have to struggle with, how to decide whether to decide one way or the other. So there's no good answer. But for healthcare workers, the idea of reciprocity, I think, is nothing new. It's something that unfortunately you have to do, to give to the healthcare workers to protect the very people who then will have to protect the rest of the population. My only concern is about the healthcare workers, and we've made this known to the government, is that don't give all the healthcare workers the vaccine at the same time. So we do not want healthcare workers, you know, who will suffer from the adverse events of the vaccine all at the same time, and therefore depriving healthcare of the very people who have to take care of the other patients. This we have told the committee again and again. I just hope that they listen, you know, because these are the things which usually escape people's attention, right? So that's my short answer. Sorry, too long. Yeah.
No, that's okay. Yeah, it's a perfect answer, actually. Dr. Rahul?
Okay. The second question is to Dr. Shahrul, and the question is by Ms. Farah Abdulaziz. The question is, does an elderly aged over 80 years old with a chronic kidney disease should take the vaccine for COVID-19? And how do you guarantee that it would not affect the comorbidities? Dr. Shahrul.
Thank you for that question. It's a very relevant one, and it's being asked across all, not just people who are older, but their relatives too. There are no clear answers for this because if you've produced or developed a vaccine in a very short time, and it is very difficult to know its long-term effects. We may have the initial short-term effects, and with any new drug, even not just vaccines, there are no guarantees. So back to your question, how do you guarantee it will not harm her current disease? We don't know this, but the best way is to wait and look at the data that's currently being gathered by the countries who are delivering this vaccine. There's very many different types of vaccines in the developed countries, and we will be able to examine the side effect. But this does not mean that an 80-year-old with CKD should be excluded from being vaccinated, just because they may have some mild or further side effects, because people will have some side effects. A lot of older people take the pneumococcal vaccine, shingles vaccine, and flu vaccine. Some have some side effects, but whether it would affect their disease very much determines what their status and what their functional ability is at that time, and how well they live with that disease. If they're well, then they can get vaccinated, even though they have all these various multiple problems. I hope that answered it.
Okay. Thank you. This is another questions addressed to Professor Datuk Wawang Bugiba. It says, in your opinion, what could be the best vaccine? How safe are the mRNA vaccines? These are something very new.
Very difficult question to answer. We have only reviewed 11 vaccines which are in phase 3 trials, which are the later part of phase 3 trials. Only the Moderna and the Pfizer vaccine have got the primary endpoint properly analyzed. But the AstraZeneca Oxford vaccine has only got an interim analysis. And we noted several interesting things about the way they analyzed, but I wouldn't go into detail why that is so. Generally, I would say the adverse events are actually very low. And so far, the Pfizer and the Moderna vaccines, because both are mRNA, have established quite high efficacy. I've actually checked the data and recomputed back the efficacy levels. So how safe they are? Well, it's new technology. That's true, and we are, of course, always concerned about safety when something is new. But for the moment, I would say I can't see any real adverse event of concern unless you have other issues. Like, for example, if you are immunosuppressed, your immune system maybe cannot cope, or you may have a history of allergic reaction or anaphylactic reaction in the past. And then, of course, I think you would be very worried anyway about taking any new vaccine or any new drug. Otherwise, and we have actually proposed a monitoring event over 2 years. Again, I have to emphasize, my committee makes recommendations for the government, whether the government actually does carry out those recommendations. And we have made some very detailed recommendations, including what to monitor and how many people we should monitor over a 2-year period, and how you collect those data and what kind of immunity you should monitor. Because we have got people with varying expertise. We've got immunologists, virologists, we've got infectious disease specialists, and so on in my committee. So there was another question, I think, how do you want to monitor? We recommend that we monitor not just adverse events. We recommend that we monitor specific adverse events like antibody-dependent enhancement, for example. We recommend type 1 interferon response. We recommend monitoring T-cell immunity, for example. So because we know that this particular disease is new, we are unsure how long antibodies will last, whether they will wane over time, and they will help us then predict whether you need a booster dose or not. So a lot of things that we have recommended to the government. In fact, we have recommended a vaccine registry above about 50,000 people, where you have active surveillance rather than passive surveillance, right? So again, that's why I say my committee has recommended a lot of things, but whether it will be taken up is another matter. Yeah.
Thank you, Prof.
Yeah.
Okay, the next question is again to Prof. Sharul, and I'm going to club 2 questions, one by Zulfikli Zafar and Peter Branham Wong. and just a summary of it, considering that there are limited resources and we have a vast population of 30 million plus, how should we go about vaccination, vaccinating people? Should we go first with those who contribute the most to the economy or to the most vulnerable? And in that context, how do you outline a proper vaccination policy to make sure that this distribution is proper and just as well?
Thank you. That was an excellent question combined. Certainly, as I said earlier, is a point worthy of discussion, and it depends on which ethical value that you address. And if you go towards the ethical value, an ethical consideration of saving as many lives as possible, then you wouldn't be going for the older and the frail in the population. However, my big fear is that if we look into those who are only contributing, then we will miss out on the cost. We will be affected by the cost, the economic impact of not vaccinating the old and vulnerable, who may present to hospital, burden the healthcare system because of complications of other diseases, and therefore have high healthcare demands that are needing to be considered. So they're in hospital for longer, they are suffering from COVID or other problems that complicate COVID for longer, and that economic impact far surpasses if you were to do the calculation, giving vaccination to those who are well and able-bodied and contributing. But this does not in any way affect the consideration for those who are the frontliners, because if we look across the country and across the globe, healthcare workers infect the vulnerable. So therefore, there's also another side of the argument. So there's no real, as you said, pleasing anyone. However, we cannot look at it in a one unilateral way. Like, for example, the Germans in the UK looking at, we'll save as many lives as possible. Well, that may be true. We need to sort of look into various other aspects as well, so that we cover all our bases, and no pleasing anyone really. But I hope I answered the question.
Okay, thank you, Prof. I would like to pose this question for our third speaker, Dr. Tarani. The question reads: considering migrants are one of the priority group in receiving the vaccine in Malaysia, how would you think Malaysians would react to this decision? And what are the advice to Malaysians who are against this decision, since the vaccine is very scarce at this moment?
Right, thank you for the question. I mean, very interesting question. You think about it, this is a controversial issue, right? And the decision makers are basically politicians, so they have to satisfy their political base, who are citizens, not non-citizens. Okay, but the decision makes sense from an ethical point of view. We talked about justice, but it also makes sense from an economic point of view. I mean, literally, we need these people who need to shore up our economy, and our lives won't go back to normal if we keep having outbreaks happening. Okay, so, but then again, public opinion actually affects how politicians make decisions. So it's really important that people like us become advocates and speak the truth. Because literally, if not, this is a voiceless community, and we have to do our part. I think that's all I can say here.
Okay, thank you, Dr. Tarani.
Now I have a question for Professor Dato' Norma Mansur. And the question is that since Malaysia has bought various vaccines from different sources with efficacy is also ranging, how would you think this is fair for those who receive a low efficacy vaccine? Norma.
Thank you. I thought it will be the question about whether the vaccines can reach the outlying areas in Malaysia, but Prof. Awang should answer this because this is on efficacy. But there's also an issue of logistics, yeah? So maybe if the efficacy is lower, but in terms of logistics, it is more practical. Perhaps, you know, those are the considerations. Yeah, but before I pass it on to Prof. Awang, honestly, I can't answer that question well. Before I pass on to Prof. Awang, I would like to add one more point, if I can. Although it was in the slides of Dr. Tarani on the social protection, investment in social protection. This is a good lesson for us that how we, because we have the universal healthcare, so many people take it for granted, including employers who brought migrant workers or employers, either migrant who are legal or illegal, it doesn't really matter, but the investment in health is very poor in this country, yeah? So if anything that we can learn from this, I mentioned for other forums, it would be investment in the overall social protection, especially the financial side of it. But in this case, it's also on the health side. So if everyone were to contribute, then of course, fiscal, the financial issues will always be there, no matter how rich the country is, but at least we have a bigger pool that we can utilize. Hence, this is one thing that the way forward is to start thinking about how health is also an investment, just like the other aspects of social protection, and think that as we've always been reminded about the pandemic, this is not the only one that's coming. It may be nearer than what we've had in the past of more than 100 years. And therefore be prepared for this. Yeah, thank you very much.
Prof. Awang, would you like to add something to that?
Okay. It is difficult to answer this question without being very technical. So I'll try to be as less technical as possible. A lot of people are worried about efficacy, right? This is the thing which worry people because, for example, if you look at the Pfizer Moderna vaccines, they're reported to have efficacy of 95%. One. Number two, I think the AstraZeneca Oxford vaccine has been reported to have varying efficacy, but those are interim results. We don't have the final results yet. They range from 70 to 90%, and there were issues with standard dose, low dose formulations. I don't know how they messed that up, but I can understand. Sometimes I think that happens. Thirdly, the Sinovac vaccine, which has been trialed in many countries, they've reported varying efficacy. Brazil has reported only 50% efficacy. Turkey said they've got 90% efficacy, and so on. But they've been trialed in many countries. So this is what worries people. I have to get away from efficacy. Efficacy happens in clinical trials. Effectiveness is what happens in the real population when vaccines are actually rolled out. Now, effectiveness typically are different from efficacy because there are other conditions which affect the effectiveness of the vaccines. Hence, that's why we told the government non-pharmaceutical interventions have to remain in place until infection level actually go down to very low levels. How low, we'll have to simulate that. We haven't worked that out because we don't have enough data from the Ministry of Health to be able to work that out, how low it can be, and we can simulate on the effects of the vaccines. Now, how do you prioritize somebody, you know, with this particular vaccine and that vaccine? This question is complicated by the fact that the primary endpoint used in the phase 3 trials are symptomatic infection, not necessarily asymptomatic infection, and not necessarily transmission. So what we are seeing coming out from the phase 3 trial results, for which people seem to be so concerned about, is symptomatic infection. A 70% efficacy, it means reduction of the infection rate symptomatically by 70% is still a very, very good rate. The BCG vaccine is still around. The BCG vaccine, trust me, it's not that efficacious either, but we still give that to millions of people around the world every year. So we should not be focused too much on the efficacy of the vaccine and whether lower efficacy means you are, giving suboptimal protection to people. because only time will tell whether which vaccines work better in reducing transmission rather than direct protection. Unfortunately, at the moment, we can only say the vaccines will give direct protection. We don't have enough data to say whether it will actually reduce transmission over time. We don't have. I've been reading paper after paper on the results. The peer-reviewed papers, media reports are absolutely useless for this kind of assessment. So I don't think we should focus too much on that. The logistics requirement, of course, will play a role. I think it has been announced by the MOSTI minister that probably urban centers will get the Pfizer vaccine because of the ultra low freezer requirements and so on. And then the AstraZeneca vaccine, for which we have signed agreements, will be distributed to the lower lying areas. Of course, the other trade-off is the AstraZeneca vaccine uses proven technology which has been used before, which is a viral vector. That's nothing new. You know, it's been proven safe in other vaccines before. Whereas the Pfizer and Moderna vaccine uses mRNA, which is new technology, but has been researched for a few years. So I guess there's no real good answer to this, but don't get fixated about efficacy. I am pretty sure that people, certainly my own committee, we keep on harping about what levels there are that you expect and how much reduction and in cases that we expect to see if you give this vaccine to a certain number of people and those number of people can function and so on. Our only problem at the moment is that we don't have this granular data from Ministry of Health. That's our only problem. We can't do really good models until we get this granular data. So don't worry too much about efficacy. Effectiveness is another issue. And I am pretty sure most of these vaccines, for which billions of dollars have been spent, has got some very clever people, designing them in the very first place. That's my not very short answer.
Okay, thank you, Prof. Maybe we just pose a more general question, and it's quite an interesting one. This is a question posed by Chin Teo. Here's how it reads. Wondering what do the panel think about Indonesia starting vaccination on young people first? So I'll repeat the questions. Wondering what the panel think about situation like in Indonesia where they start vaccinate the young people first.
Can I answer that?
Yeah, go ahead.
Yeah. I was in a roundtable yesterday organized by NUS. We had people from Indonesia, Laos, Vietnam, Philippines, and India. All of us were talking about the vaccines. We were in some way or other, advising various governments on this. Now, I think the speaker from Indonesia said that they were thinking about the economy. Basically, that's why they're concentrating on the younger people. You got to protect these people to make sure that the economy, continues as usual and it's not affected too much. Now, of course, Indonesia, comparatively compared to Malaysia, I think doesn't have that high proportion of the older population. And they've already started vaccinating people anyway. The last month, they've started with the Sinovac vaccine. President Jokowi was the first one, I think, to receive his jab. And I think that will, again, depend on the country and what their focus is. Do you want to protect those essential workers first, prioritize over the older ones? There are people who, like in the UK, they start with the oldest age group and move downwards, move to the younger age group. So you look at the 11 priority groups in the UK, the JCVI, they start with the oldest one. In fact, the very first person to receive the vaccine in the UK was a 90-year-old lady. I think she's 90-year-old, but she looks extremely fit for somebody who's 90. So depends on what the priority for the country is. And the reason why I think the UK prioritizes the older population, because they got a lot of deaths in their nursing homes. The ones who are elderly, their deaths are very high. I think Prof. Shahrul can testify to that. So it's not so much the younger ones, but the Indonesians think that they've got to protect those people who really, are important for the economy.
May I add very briefly to that, Prof. Awang?
Yes, go ahead. Go ahead.
Yeah, Dr. I do think that Indonesia has a different healthcare system and priority areas. In discussing with my colleagues who are fellow geriatricians in Indonesia, the burden of the healthcare utilization by the elderly, especially the very elderly amongst Indonesians, is very low, very, very low. So you hardly see the elderly in hospital. They tend to die at home. And but this is mainly because, you know, as big as Indonesia is, there's still a very well-defined rural and urban population. So this may be different in some urban populations, but largely by far the very elderly are often at home. So when we were training a few geriatric trainees from Indonesia, they were so shocked that they found the elderly in our hospitals because they never really treated one with a person over 75 before. So for that reason, and we are not far from the UK in that, because in that a lot of our elderly now are in urban areas. Aging is occurring in urban areas, and therefore the exposure of older people to healthcare and their demands on it are going to be high, and therefore it needs to be a balance between young and old. Thank you.
Thank you, Prof.
Prof. Sharul, a related question for your comment, perhaps you'd like to answer that. This whole controversy regarding the Norwegian COVID-19 vaccine, issues related to deaths amongst the elderly,
Yeah.
and also how would you address the apprehensions that something like that could happen in Malaysia as well?
Well, you know, if it can happen there, it can happen anywhere. However, I must add that the Norwegian officials have adjusted their advice on who gets the vaccination in light of these deaths, of course. But what we need to know of these 13 deaths, or 23 deaths, if I'm not mistaken, is that what was the condition and degree of frailty that these patients were in? What was their, you know, current health status? And what were the side effects that they suffered? Was it something that was monitored closely? Because they are dealing with very, very frail individuals. And this relates to another question that someone had posed. How do you monitor the side effects, especially if you're delivering it to very vulnerable populations? So, you know, our Faculty of Medicine, have developed the Cosmos system, which is a home monitoring system. SPM, Prof. Awang, and Dr. Tarani, you know that very well. And that's one of the ways in which people relate their symptoms. So it's an online portal, and if the delivery of the vaccine to specific elderly populations or vulnerable populations are to be monitored well, and their side effects, then such a system must be in play to coordinate all this delivery. So, so for example, the deaths in these 23 Norwegians, the side effect tolerance of the particular vaccines may include nausea and vomiting. So if it's not addressed early in the severely frail with underlying cardiac conditions, kidney conditions, etc., this may cause harm, and that's why they die. But you know, I was criticized for sort of there's a very extreme view, but we were having a heavy debate about with penicillin side effects. 1 in 5,000 have anaphylactic shock. With vaccinations, what is the figure? Is it 1 in 100,000? Why is, you know, what is the balance? So again, you could have very many heated debates about this, but I guess that is because vaccines usually take 7 to 8 years to develop, not 7 to 8 months.
To add to that, the debate is because, I mean, vaccines are given to generally healthy people. So especially if you're giving vaccines to children, healthy children, to protect them from disease, we have very low tolerance to giving a potentially harmful vaccine. So that's why safety is such an important concern. And that's why things like the risk level of 1 to 100,000 is tolerable, maybe. Compared to drugs like penicillin and so on, it's treating an illness.
Yeah, so hence very, very different. So, you know, someone deigned to actually make that comparison. So that created heated discussions. Yeah.
You're muted, I think, Dr.
Yeah, this is also a question. This is a question actually addressed to Dr. Tarani, so I'm going to read it out. It's regarding international students. Is there any policy in place to prioritize the vaccination of international students across all universities in Malaysia as a whole group, rather than including them under other migrant groups?
Actually, we have very little information about what the government policy is to prioritize vaccination. I mean, we are talking about all the recommendations and different countries and so on, but we do not know what's happening. I mean, we do not know as yet what will be the priorities of the Malaysian government. So we will have to wait and see. But you have to consider all the list of ethical values that we were talking about earlier, you know, so benefits the entire society, justice, reciprocity, and, you know, those kind of things before we look at one particular community.
I'm also waiting for the government to come up with the immunization plan. They have not announced it. So you know, until I see it, and I don't know whether the recommendations of our committee have been taken up. I just hope so. If not, then well, that's a lot of work for nothing.
Yeah, and another point is, I guess, why it's a point of concern is because of the fact that this vaccine is a precious commodity. It may not come to the private market for a long time. So you will not be able to buy it just because you have money. It may not be available. So we have to wait for the government allocation. So this is the controversy.
There's another controversy internationally, of course, is that I call this vaccine hoarding. You know, some countries have actually bought enough to vaccinate their entire population 2 to 5 times over, and I cannot for the life of me see the reasoning behind buying 5 times whatever you need. You know, you can't really keep the vaccine for a very long periods of time. They will deteriorate, especially the mRNA vaccines. They are very sensitive, and they don't tolerate storage for a very long time. So like Canada has bought 5 times whatever it needs. So I can't see the reasoning. What do you want to do with those excess vaccines, unless you want to donate them to poorer countries or to COVAX or whatever, you know? Yeah.
Thank you for your response.
I think if I may use my privilege as a co-moderator and ask a question to all the panelists, particularly Professor Evang or Prof. Norma. We understand that there is this moral conundrum and there are a lot of technicalities involved, but for a lay person like me, what is the way forward? Where do we go from here? We understand that there are different kind of vaccines. We understand that it's, for most of the countries, at least, it is not enough. So how's 2021 going to look like for common people like us?
Before Prof. Norma answers, maybe she'll answer from her point of view. Let me tell you this. The government has already signed agreements to purchase about 50%. It will cover 50% of the population. But eventually they say they will be able to cover about 82.8%. Now that's more than what we slightly more than what we recommend. We recommend around 80%. And that 80% that we recommend actually includes children. But children, we don't really have data yet. The Pfizer vaccine is the only one which has been tested up to the age of 16. Below 16, they're just beginning trials now. The other vaccines have stopped at the age of 18. So nothing trial in under the age of 18. So if you consider the age of 16 as a cutoff point, 70% of the population is 16 or older. So 30% of them under the age of 16, which means 70% you would have covered everybody, every adult population. Now, should you vaccinate the children or not? Well, we have to see whether the trial data tells us whether it's safe in children or not. That's one thing. Another thing that we have worked out for the government is that how long will it take to vaccinate this 80%? Worked out 80% of about 32 million people is around 26 million people. We think it will take between 300 to 500 days. 300 days if we use 1,000 vaccination centers at the rate of about 15 minutes per person. as you make sure that they also don't suffer anaphylactic reaction. So we have to hold them for about 30 minutes or so. So one nurse should be able to complete a certain number. So we think 4 nurses should be able to complete about 128 vaccinations per day. And if we do this, we'll be complete about 20 plus million in about 300 working days. So if we continue longer than 8 hours of working, then probably we may shorten it. Or we told the government, if you pre-register people, you can work this out faster. And we even told the government where to find these people. We worked out how many people have diabetes, high blood pressure from the mobility surveys that has been carried out in the country. And we told them, you can find these people looking in the Malaysian Health Data Warehouse, the NCD registries, the non-communicable disease registries. You can find them in the TPC, the Tele-Primary Care database. You can find them in the health center records, because having worked in a health center 25 years ago, I know that we see hypertension, diabetes as a matter of fact in these health centers. We have clinics for them. So we have records, so we know where they are. So you should invite them and find out, provide a system for them to register, pre-register, and work out the appointments so that you can do this on a systematic way and finish this vaccination. So it will take at least 300 days for us working continuously 1,000 vaccination centers to finish vaccinating 26 million people. That's what we told the government. Now, that's why I'm really waiting for the national immunization plan. Have they considered all these things that we worked out for them? Where these things come from? We even told them, why don't you come up with an app? You can even copy the Cosmos app that we have for monitoring, the ones that has developed. Well, I really don't know. So maybe Prof. Norma, the other aspects you can answer.
Oh, I like you. I don't know much about this either, but I think I shouldn't speak on behalf of the government. My own experience is their consultations with groups like Prof. Awang, Prof. Charo, and also Prof. Tarani, perhaps. They take all these points into consideration. Of course, they have their own internal meetings, etc. But it's good to have these voices. It's good to have these discussions, because this is where they pick up for their policy making as well. And I think maybe the reminder that has always been is this is a new normal. Dr. Rahul, I'm like you, I'm a layman too, yeah? So this new normal would mean that we cannot go back to where or what it was like. So we will still have to follow the strict standard operating procedures, despite, while the COVID while the vaccination is ongoing and all that. I think that's the best that I can say. And with regards to how the government is managing, I think in the past, of course, I was part of the group that the NEAC Secretariat, the Economic Council Secretariat, was part of that group. And the voices of economics or the economists were not as strong, it was public health that was of a stronger, more dominant voice. But I think you too have been hearing that even non-economists are talking about, okay, do we die of COVID or do we die of hunger, So these are some of the things that the government will have to, and we are fortunate this afternoon that we are all like-minded, but you talk to some other groups, you'll be surprised that they have different opinions on some of these things. So so that's my response. So I think for us, a way forward is to observe this the new normal, and while waiting for vaccination to happen or to reach the level that is supposed to create the herd immunity. Thank you.
Thank you, Prof. Norma. If a very short question, if you could just give a quick response to that. what about those people who are too apprehensive to be a part of this entire vaccination scheme? I mean, they just don't want to be part of it because they are very afraid. How, what about them? Are we counting them in? Are we including them? Because this is also a question related to access monitoring. And these are, of course, these potential, if they are not vaccinated, then you might face difficult situations later. So how would you respond to that? Or if you want to pass it on to.
Okay, I don't know who's going to answer this, but let me give it a try. Uh, there's supposed to be a communication committee set up answerable to the Jatuh Kuasa Jaminan Access Vaccine, the JKJAV. The JKJAV is co-chaired by two ministers, MOSTI as well as the MOH minister. And I'm not part of this communication committee. So, but one of the things that we've reminded the government that communication is absolutely essential, because people need to be reassured, people need to understand. And we said that I kept on emphasizing that you don't get a second chance to make a good first impression. So, we said that the message must be non-condescending. So don't talk down to people, but put it in very clear terms, why we need to have vaccination and to reassure. So other than that, I'm not a communication specialist. I've already said that we really need to get behavioral scientists on board, and communication specialists. I'm just a lowly epidemiologist, so I don't really understand how people's behavior, work. Yeah.
Okay, thank you.
Yeah, maybe Dr. Tarani, yeah.
Yeah, just another point of view also. I mean, that's one of the reasons why a lot of countries do not make the COVID vaccine mandatory. We are giving people the freedom. I mean, the governments are giving people the freedom of choice, so they can make an informed decision. They can take the. I mean, we talk about ethics, right? So they can assess their own the benefits of the vaccination, but also the harms of the vaccination if there's potential harms that we don't know about. So we can't actually force people to take it. Yeah, so the person has to make an informed choice, and I think that is the best way.
Okay, great, thank you. Maybe this is this is just one question that any of the panel can answer. It's also a bit regarding okay, maybe I'll just read the questions then. So this is with regards to the vulnerable group. So the question is that regardless of the group to prioritize, do you agree that the principle of informed consent must be upheld for COVID-19 vaccine? How do you ensure an autonomous and informed process for the high risk, like the elderly and the vulnerable groups for COVID-19 vaccine? I think any of the panel could answer.
Oh.
Hello?
I guess vaccines, I mean, literally informed consent is really important. I mean, the idea of informed consent is basically the individual makes the choice based on proper understanding. They're not just given the information, they have understanding of the information and that ability to evaluate and make that decision and weigh the harms and benefits. So yeah, it would be an issue vaccinating people with dementia who cannot make that decision, or if you're going to go around giving people who like migrants, for instance, and you're not informing or explaining this to them in their language, so they cannot actually understand, that would be a force. So it's against ethical values.
May I just very briefly also add to that, with Dr. Sarani mentioning, of course, informed consent is going to be a big concern and must be considered in every person receiving a vaccine, young or old for that matter, because even the young can can decide. But of course, they have legal guardians. So do older people who are cognitively impaired, especially those with moderate to severe dementia, because they may not realize the implications. And therefore, there is the power of attorney. There are people who are advocates for them that need to help explain to the caregivers, especially those who are socially vulnerable, different ethnicities, who are the poor, etc. It may be a difficult concept to realize, and especially if they're made to pay for it. If they get it free, that's not that may be there. Well, that's another issue altogether. But yeah, the vulnerable are a concern, and getting informed consent must be thought out very carefully.
Can I just respond? This just coming from probably Prof. Awang had also highlighted this point in response to the earlier question. It's also about trust. Yeah, that the citizens or the people will have to trust the government. And how do you gain that trust? Is through communication. Yeah, through communication and being transparent. If you need to explain 3 times, then maybe you have to do it 3 times. But it's not easy. But also, as we can see from the swab test and the test that's happening around the country, also you have news about how people, was it got to the brain or something when you did the the swab test, and I went for the swab test. I mean, it's not at all. I mean, it's so you get all these kinds of news that people are, and yet many people are going for the test. I mean, voluntarily. Yeah. So if they know that it is good for them, because you have to remember this, it's not just about protecting you, but also protecting people around you. And this issue about ethics, I think, has to be also extended to also include that when you are not taking for yourself, maybe you are being selfish because you are not considering the how it would impact others. Yeah, so it's not just about your own health, but not taking it. Then it means that you're not you're being selfish because you can pass it to others. So it has to be. But as Prof. Awang said, who am I to say all this? I'm not a behavioralist, but I think I always believe, I mean, from a public policy perspective also, we always believe in engagement, consultation, and communication. So it has to happen now. So if if the plan, the big plan, if the plan is out there and it can be like in February to start vaccinating, I think the communication will have to start like yesterday or last month. Yeah, talking about these issues. Yeah, these issues of ethics. We can't make it mandatory, but look, if you don't do it, just like the swab test, you'll be going around infecting your loved ones. So you may not die, but your loved ones will die. So those are the kinds of efforts that, or the kind of plans that will have to be part of the actual vaccination. Yeah, if I can say that. Yeah, thank you.
I think Dr. Norma has made an excellent point. I keep on telling the authorities, even the management of the pandemic itself, that while people like me, epidemiologists, and we deal with numbers and strategies, but it is absolutely essential to get behavioral scientists on board, because how do you ensure that pandemic fatigue does not set in, SOP fatigue does not set in? And I've said this again and again and again. I think I'm tired of saying this. We need to understand people's behavior, to understand why people are not complying. For example, is the message not clear? Are there issues about perceptions of double standards and so on? If people see that, then because generally I believe people are reasonable beings, provided we speak to them in a non-condescending manner. I don't think anybody likes to be spoken, talked down to in a condescending manner. So as an epidemiologist, I'm saying behavioral scientists are also equally important. in managing this pandemic and getting this vaccination. I don't know how many times I've told the ministry that please get this done quickly. And, you know, like Datuk Roma said, it should have started yesterday. Because if you're going to start in March, we have only got about a month or so before we start vaccinating. And there are lots of things to do to convince people that they're doing this not just for themselves, but to protect others too, especially their loved ones. Yeah.
Thank you, Prof. Dr. Rahul, the floor is yours.
Thank you, Professor Awang and Prof. Norma, and all the panelists. For the benefit of the audience, I think if we just do a quick wrap up and I highlight a few key takeaways that would be, I think, good for all of us. I think this whole debate that we had this afternoon gives us a lot of hopes and anxieties too. And concerns at the same time on part of policy makers such as our panelists and also the government. And the concerns are many. For example, children below 60 have to be vaccinated and the target should be 80%. But then what about the old age people, those who are not immune enough and have several comorbidities? What about the refugees and the people who are disabled, people who are not in a position to decide for themselves, or those who fall outside of this interest to get vaccinated? These are questions that put up a sort of moral conundrum before not just the policymakers, but also informed citizens and informed residents in Malaysia. And I think in that context, vaccinating as many people as possible and also monitoring the developments, both positive on the negative side and the negative side, is very important. Mortality rate, of course, is an important question there. But from a political scientist's point of view, I think the solution here is what a great political philosopher, John Rawls, had come up with. Justice as fairness, that you have to, in providing public goods, such as the vaccine, you have to not only include the most able people and those who are, you know, part of the future generation, but also the vulnerable, those who are marginalized, the refugees who are forgotten. All this has to be included in the Rawlsian kind of justice system. And this would also include some more important ethical questions. Refugee, for example, is one, migrant workers, another one, disabled people, and all these categories, because you put all this together, this is what defines Malaysia or would define Malaysia as a nation. What we are is very important and should be very important in determining our future course of action, in not just in terms of vaccination, but also in terms of finding possible solutions and getting back to a normal state of affairs. So I think John Rawls is something that comes to the minds of political scientists such as mine. And I would like to stop there. And on behalf of the audience, I think I must congratulate and must appreciate all the panelists for their very insightful and thought-provoking points. It was really an honor for me to be a co-moderator for this session. It was really very, if I may be honest, I can say that this was the most informative for me and very balanced on the ethical side as well. One of the sessions on vaccine and this whole politics and policy related around it. So on behalf of the Asia Youth Institute, I thank all the panelists and also on behalf of all the audience, because they cannot really do a round of applause for you. Also our partners, Center for Law and Ethics in Science and Technology at the Faculty of Law, UM, and the UM-RAC, University Malaya Research Ethics Department. On behalf of all these, I thank you once again, and take care and stay safe. Now I pass on the floor to Dr. Lee Luan if she wants to add something.
Thank you, Dr. Rahul. I'd like to convey my appreciation to all the speakers for such fantastic talk. And I think it's really a smorgasbord, a good smorgasbord of topics, if you can put it that way. And I think, we need more discussion like this in the future. And we look forward to more this sort of discussion, whether it's organized by anybody in UM or outside of UM. And of course, like Dr. Raul, on behalf of the audience, also a big thank you to all, to the organizer, the people working behind that you don't see. They are the technical people. You don't see them. Yeah, let's give them a round, a round a round of applause. And then with that, thank you everybody for your questions. Unfortunately, it's kind of impossible. It's impossible actually to answer all the questions. Both Dr. Raul and I were so busy trying to combine questions and look for questions and so on and so forth. And if we didn't do a good job, I really have to apologize for that, because but it was really very stimulating. If you look, if only you could look at the list of questions that we were looking at consistently and changing and so on. So yeah, let's keep up the conversation. I think this conversation needs to be kept up. And also like, I especially like what Prof. Nomar said, is about from different perspectives, it's like the justice, are we ready for it? You know, the social science aspect, I think. And also I'm from the language faculty. And I think there's not enough talk for lay people to understand. I mean, all this while, my understanding is that you have to have certain level of education to understand what's going on with regards to the vaccine, if you look at the terminology used in the newspaper and so on and so forth. But it always piqued my interest that, you know, what are those pakcik-makcik, you know, what are they talking about in terms of vaccination? Because, you know, I'm interested to know what is their knowledge at this stage, because they are a group of us. And in fact, some of them are going to be the one who get the vaccine first. So, you know, what is their understanding? You know, what is their thought about this? But yeah, I mean, like, this is a $1 million question. So with that, thank you very much, everyone. We will see you at some point in another webinar organized by AEI. Thank you.
Thank you, and bye-bye, everyone.
Bye-bye.
Thank you.
Thank you. Bye-bye.
Bye-bye.